Hi, Dr. Vasili.
How are you doing?
We're doing well. Thank you so much for joining. We can go ahead and get started at your leisure whenever you want to pull up the slides and go ahead and share those.
Okay, great. I'm just going then to share the screen.
Let me know if you have any issues with sharing. You should be able to.
I think I should be able to. I think that you see my screen, right?
We can. You're all set.
Perfect. Well, so first of all, good afternoon, everybody. And it is truly a pleasure to be here and meeting you at least virtually today. I do share my screen, so therefore I have no idea who is here. But hopefully at the end, we'll have a chance to engage in a very interactive discussion. My name is Odika Pobusui. I am a professor here at the University of Michigan. I'm the vice chair of clinical research, and I'm part of the MCT2D endocrinology group. And I had the honor to be elected the president of Medicine and Science of the American Diabetes Association. And with that introduction, I would like us to go over several topics that we consider as being very important to best move our project forward. So, as you know, one of the quality improvement initiatives of the MCT2D is how to optimize the use of some of these newer medications that have been developed originally for lowering glucose in people with type 2 diabetes, but they have emerged in the last several years of having unexpected benefits on a variety of complications, particularly atherosclerotic cardiovascular disease, heart failure, and chronic kidney complications. So with that in mind, we wanted to see what is the current state of affair. In other words, what are the guidelines that exist in the management of people with type 2 diabetes, and also share with you some of our preliminary analysis that we have identified within the MCT2D collaborative of how these agents are being prescribed. Of course, we are going to show you today data that is pertinent to the endocrinology practices that are participating in our collaborative, and then we will have time to have an open discussion. So let's look at the guidelines. And before we go to the guidelines, I'd just like to highlight, of course, some also hot off the press data that has been released by the National Clinical Care Commission in diabetes, demonstrating this continuous costs in diabetes healthcare in the United States that are really reaching pretty high levels. And the reason actually of these costs are the development of these various complications that can in fact affect the entire human body, as you very well know. Additionally, one would have expected that with this continuous change in the standard of care and with this continuous improvement in strategy and medication, we would see a downtrend in the incidence of these complications. And we were doing that up until 2010. But what is really worrisome, and this is also very recent data that was released by the CDC, is that in fact, in the most recent year, there is a worrisome upward trend, which actually applies to the cardiovascular, like MI, stroke, lower extremity amputation, and end-stage renal disease. And this is particularly happening in the younger people with diabetes, as you can see here, ages 18 to 44, 45 to 64. And that's definitely adding additional concern, because those are those patients who have a much longer life expectancy, right? And most recently also, actually also quite hot off the press, is that now heart failure is emerging as the most prevalent cardiovascular complications in people with diabetes. And this is actually valid across both type 2 and type 1. In fact, the findings for type 1s were extremely surprising. This is just a sample of these very large cohorts of people that have been followed, as you can see here, from anywhere between 3 and 30 years, that have shown consistently that that's actually the case. And as I said, this is just few of the studies. The consensus is free for everybody to use. So that's most of these guidelines, and here is the ADA, American Diabetes Association, standard of clinical care, are concentrating on several pylons of management that do include not only the glucose, but other risk factors management, lifestyles, to try to reduce the incidence of these complications. Definitely many of these guidelines that we are going to review have been changed in the last several years because of, as I mentioned earlier, the data that has resulted in these very large cardiovascular outcome trials. And I'm just going that you are very aware of, but this is just the most recent meta-analysis looking, for instance, at the GLP-1 receptor agonist combined data sets from the major CVDOT trials with the GLP-1 receptor agonist, definitely showing this consistent 14% reduction in the risk of major cardiovascular event, 13% reduction in the risk of death. And very interestingly, for the, about that, for the GLP-1, they seem to have a clearly benefit also on stroke. And here is the data on the SGLT2 inhibitors, whether we are looking at the composite MACE cardiovascular outcome, the cardiovascular death, their benefits are very clear. And more recently, the benefit on heart failure and CKD progression have also consistently emerged with these agents. So having this data in mind, of course, we wanted to ask you questions regarding the guidelines with respect to these therapies to prevent cardiovascular and chronic complications in people with type 2 diabetes. How familiar are you? And you don't have to answer right now. Okay, actually, yeah, I think that Jake already had put the, how familiar are you with the guidelines that are available for people with type 2 diabetes? So you can select your answer.
They are selecting answers now, and I will share it as soon as we have everybody's response in.
Okay.
All right, I'm going to end the poll and go ahead and share the results here. You should be seeing them now.
Okay, so excellent. So we do have majority of the audience, as expected, is mostly familiar. But you know, this question it's a little bit tricky because guidelines are many. And in fact, here, if we look, we selected for you the most recent and also let's say, use type of guidelines. So here is the American Diabetes Association most recent guidelines that now indicates very clearly that in the presence of atherosclerotic cardiovascular disease or lots of high risk, in fact, either GLP-1 or SGLT2 with proven CVD benefits should be in the first line. If a person is known with heart failure, definitely SGLT2 inhibitor are now considered an element of care or first line. And the same is true for CKD, for SGLT2 inhibitor. And of course, there are a variety of other steps that take into consideration how to minimize hypoglycemia, how to minimize weight gain, and then, of course, access, which are less relevant for the collaborative goals at this point. So this is the ADA. American Heart Association also came out with guidelines also this year that they revised. And here are those guidelines for your information. As you can see here, they do keep in in the center all this glycemic management and are adding this SGLT2 and GLP-1 as expected element of care because, but they also actually implement here a step about effective screening. How do you screen for cardiovascular disease, whether it's atherosclerotic cardiovascular disease or whether it's heart failure. And they are also including for the first time, in fact, the importance of these various social determinants of health in the management of people with type 2 diabetes. Here is this most recent, again, consensus that the American Diabetes Association and American College of Cardiology had just released, again, concentrating specifically on heart failure and looking at these various stages of heart failure, stage A, B, C, and D, with the goal of identifying people as early as possible in stages A and B, and then applying a differentiated treatment. For many of you who are part of the American Association of Clinical Endocrinologists, or ACE, ACE had put guidelines quite frequently. These are the most recently published, 2019, although the 2022 are going to be available very soon. So they also have their approach looking also glycemia as well as various risk factor control in the presence of comorbidities, including cardiovascular disease. And here is the KDIGO guidelines, again, re-updated in 2022, in which they also have their pyramid of guideline-directed therapy for people. Of course, they are specific for people with diabetes and chronic kidney disease, keeping in mind, of course, that most of the people who have chronic kidney disease in diabetes also have a form of cardiovascular disease. So those are, I would say, the most, up-to-date guidelines that really are including people with diabetes with either CVD or CKD that have been most recently updated. And with that in mind, we would like to ask you the following question. Majority of you said that are familiar with guidelines, but could you please share with us which guidelines do you follow in your practice? The American Diabetes Association, the American Heart Association, the American Association of Clinical Endocrinologists, the KDIGO guidelines, none or other. And Jake is going to share with us as soon as you guys finished your vote. So ADA 33, ACE 50, KDIGO 0, American Card 0, none, 17%, very interesting. Okay, that's very interesting data. So let's go next. So with that background in mind, let's see how what we have learned by just analyzing some of the data on how these newer agents that have been shown to have so much benefit in people with type 2 diabetes are being prescribed among our own MCT2D participant member. Before we go there, we just also wanted to share with you some data regarding how these guidelines translate in clinical care nationwide. So here is some data that was presented, in fact, at the American Heart meeting, published in Circulation. And you can see here that here on the left are prescription rates for SGLT2 inhibitor and GLP-1 receptor agonist in patients with type 2 diabetes and heart failure. And this is data from a large academic tertiary health system. As you can see here, the patterns are increasing, rightly so, because more and more data became available with these agents, and also the level of comfort in prescribing these agents has increased among physicians. But yet, unfortunately, as you can see here, a very low percentage of even people with heart failure are benefited from these agents, and similar patterns we see here in people with atherosclerotic cardiovascular disease. But this is just one academic center. Here is data actually also quite hot off the press, and this is actually quite impressive because this study published in JAMA recently looked at more than 324,000 people across the entire US, sampling several health systems, and they looked at how all these guideline-directed therapy that include lipid, blood pressure, and glucose-lowering pharmacotherapy in people who had specific atherosclerotic cardiovascular disease are being implemented. And of course, statins are leading with about 28%. Blood pressure medications are leading with 40-50% of people adhering, statins 28. But when we look actually specifically at this SGLT2 and GLP-1 receptor agonist, in fact, only about less than 4% in this very large and representative sample are receiving these agents. So let's look now at our collaborative data. We would like, of course, to disclose that this is yet very preliminary, but we were able, actually not myself, I just benefit of working with phenomenal people like Jake and Jackie and Kathleen that were able to do this. But we looked at all persons with type 2 diabetes in any participant practice who has been seen by an endocrinologist within our collaborative at least twice in the last 12 months. We only had access for the moment for those people who had either Blue Cross Blue Shield of Michigan PPO and Medicare Advantage coverage. So that's a limitation. We have only have some very small sample size in some cases. And also some of the variables that we are going to list with you may have been shown on various unit scales. So those are still limitations that we are trying to clean out and, of course, enrich. And also, we did not have access to medication data for patients who also had pharmacy carve-outs. So here we are looking, for instance, we just want to share with you some phenotypes of the patients that are being seen in these practices. And we looked first at the A1C level. So if we look at the entire cohort that we had data on, the mean A1C, median are actually not bad at all. Also, it's not surprising because these are people that are being followed by you endocrinologists who definitely have the highest knowledge and also expertise to manage that. We also looked at split by age, 65 and older and younger than 65. And as you can see here, it seems that those who are older are having a little bit tighter A1C than those that are younger, but this is not quite significantly from statistical standpoint. And then also we look at gender distribution. So as you can see here, female tend to have a better control than men. Again, nothing surprising there, right? We also wanted to provide you some information on the phenotype regarding BMI. Again, not surprising for type 2 diabetes, mean, median. There are quite in line, in fact, maybe slightly more obese than the majority of people that have been included in this outcome trial, both with the GLP-1 and the SGLT2, but pretty close, right, as far as obesity. And here is the eGFR. Again, not bad. If we look at the mean eGFR, about 75, so not too bad in this sample size, but as you can see here, this is a much smaller number that we had access, at least in this preliminary analysis, on the eGFR. And here we also started to extract some data on LDL cholesterol on this patient population. Again, it's not the entire number, but data is emerging. So here is how we compare. Now we have actually a very nice comparison because we can look at this very recent paper published in JAMA by national standards, and we can look at you, and you guys are doing definitely so much better because look here, 10% versus 3.9 and actually versus 2.8 in the national sample size, and the GLP-1 in our collaborative 17%. So that's actually pretty encouraging and definitely much better, at least for now, compared with the national sample. We do have about 22% of people receiving insulin, and here is the data based on various forms of insulin, and then sulfonylurea still about 10%, metformin 29%, and then we also looked to see how the collaborative is prescribing continuous glucose monitoring devices. You know that another one of our quality improvement goals is to try to see how we can increase the availability and access to CGM devices to people with type 2 diabetes. We have shared with you during the various lectures all this most recent evidence that clearly demonstrates benefit of CGM in people with type 2 as well. But this is still lagging as far as prescription, and definitely, you know, the coverage and access are likely playing a role. But I like to highlight that given the national data. So here we also looked a little bit more, tried to tease out some of this information and look at, for instance, average A1C and percentage of agents that are being used. And as you can see here, insulin, GLP-1 and SGLT2 are actually being used, particularly when patients are not meeting the A1C goals. Their use is substantially lower if the A1C it's lower. Not surprising, although I think that now with this most recent data, particularly from Emperor program and DAPA heart failure and DAPA CKD, we know that in fact SGLT2 are beneficial regardless of the blood glucose levels. Let's look a little bit more to see who is likely to get an SGLT2 and or a GLP-1 prescribed, and we looked here at prescribed medication based on an LDL cholesterol, whether they were on a statin or not on a statin, the BMI level as well, whether they were you know, overweight or obese, and here it's data demonstrating obviously higher percentage of agents being on these agents when they had more risk factors, being on a statin, having a higher LDL cholesterol, or being more overweight. This is our data on eGFR. Again, eGFR above 60, 45 to 59, 30 to 44. We see a trend here that although SGLT2 inhibitors have now very strong evidence of benefit for preventing future deterioration in EGFR, and the EGFR had been lowered actually in the 20s now, still in these more advanced stages of kidney disease, the prescription rates are substantially lower. And the same is true for GLP-1, which is kind of surprising because definitely GLP-1 receptor agonists do not have any dose restriction, given the fact that they are not metabolized to the kidney and they are not cleared to the kidney. But we see exactly the same trend here for this prescription pattern. And plus, we do have some evidence, at least with dulaglutide, that it could have benefit on CKD progression. And regarding the CGM, and I think this is the last piece of data that we were able to have for you for now. We look to see what's the likelihood to have a CGM prescribed based on A1C being lower than 6.5 versus greater or equal to 6.5, since majority of you are following the ACE guidelines. They definitely have defined the A1C optimal at 6.5, right? We see here that definitely, as expected, those who have higher A1C have a higher likelihood of being prescribed of CGM. So that we wanted to have also in our open discussion. First of all, what's the impression that you have so far on this data? See whether you would be interested to see additional type of data that are within reason to be obtained through the collaborative. And then, of course, brainstorm together on how to make the the access to guideline-directed therapy for all our patients with type 2 diabetes who qualify much, much higher than currently is. I think that many people have been wondering also lately, well, who owns prescribing SGLT2 or GLP-1? And I don't think that indeed anybody owns their prescriptions. We all do. All of us who take care of people with type 2 diabetes need to make sure that we try to treat them in such a way that we prevent any more progression of their disease, any more progression of complications or development of new complications. And this is how we are also here, particularly the CQI Coordinating Center support that has created this algorithm and all this dashboard of support that it's available for you to help you with coverage for payer, whether there are any precaution, any dosing guidelines, and all of this information are available, and how to implement the decision guide and guidelines that results in the end in better outcome for all our patients. I think that Jake has prepared additional poll questions, and those are actually great questions. So let's see. Let's go with the first one. How comfortable are you to give an SGLT2 inhibitor to someone who has a toe or foot amputation?
So, Dr. Pasui, this is when I launch this poll, it's going to launch all three of these questions at once. So it's just a quick 3-question poll.
Oh, okay. Okay, great. I thought that they are individual. Yeah. Okay, so then we will just run all three. The second question is, how comfortable are you with prescribing an SGLT2 to patients with an EGFR between 30 and 45? And the third one, how comfortable are you with diagnosing heart failure in people with type 2 diabetes?
All right, I'll go ahead.
Yeah, go ahead.
All right, here it is. All right, I think we have everybody that we have here. I'm going to end the poll and go ahead and share the results. All right, so I'll scroll down after we look at the first one.
Okay, so the first one we have majority, I would say they are somewhat or mostly comfortable. We are keeping this data, yes, Jake?
Yes, we will have the results of these polls, yes.
Okay, good. Although there are some people who are not at all comfortable, and we can open that for discussion. If we scroll down, how comfortable are you with prescribing SGLT2 in people who have an eGFR between 30 to 45? Again, majority are mostly and very comfortable or somewhat comfortable. But it's excellent that nobody says that they are not comfortable. And then how comfortable are you with diagnosing heart failure? And majority of you are, I would say, here between a little and somewhat comfortable. Excellent, very good. So with that, I think that we can open up for discussion. I can stop sharing the screen. We have, for this initial meeting, we had an hour and we wanted to leave enough time for discussion based on the data that we've shared with you, based on by the guidelines, and if there are any other conditions that you believe that may be important to be including in when we are meeting with the rest of the collaborative members at large.
Yeah, this is Dr. Hamoud.
Hi, Dr. Hamoud.
Hi, how are you doing? You know, I think the statistics for the use of GLP-1, 17% versus 3%, and the SGLT2 inhibitor, I think, yes, you are way much better than a non-endocrinologist, but I think that's still very low.
I agree.
You know, and to be honest with you, in my practice, I think, 50% of my patients are on GLP-1. So we, the endocrinologists, we have to use it much, much more frequently and to be more, so there can be more stronger advocate when because patients go and tell their physician. I mean, actually, a lot of primary care physicians, they will hear from their patients, I'm taking GLP-1, I lost weight, my A1C is such and such. So the best messenger for this good result really the patient, and unfortunately the primary care physician. But I think the endocrinologist, we have to find a way to encourage more use of this agent, because there is no doubt they are a fantastic agent, make a huge difference on weight loss and A1C reduction, and now with the cardiovascular and kidney and heart failure. So I really think that every type 2 diabetes should be on this unless there's contraindication or for some reason the insurance does not cover it. Now, fortunately, now Medicaid, I have almost 80% of my Medicaid patients on Trulicity, because Trulicity is covered by Medicaid. And they are seeing, for the first time, those poor Medicaid patients, they are seeing fantastic results. They are seeing a good A1C. So I'm not happy actually to see that endocrinologists using only 17%. I would expect, with all these beautiful studies and outcomes, we should be at least 40, 50%. That's my goal.
So again, as I said, this is preliminary data, and it includes a relatively select sample of people that we had access for the moment to analyze. But I completely agree with you. Everything you said, it's absolutely right. Anybody else would like to also comment and chime in and see what else we need to do to, and actually it will be our role to decide what are the steps that needs to be done to improve the quality of care in our people. And that's why we wanted to have a sample and understand, among the endocrinology practices here that are part of the collaborative, where do we stand, by implementing these guidelines, and where are the needs that we need to improve moving forward. Who would like to also talk next?
Dr. Pop, this is Abdullah Kassab, your colleague. How are you?
Oh, good. How are you doing?
We were fellows together years ago. And so I think this is a very impressive and interesting data. And in the end, the practicing clinician, like Dr. Hamoud mentioned a minute ago, we are bound by the insurance coverage. And I think everybody believes in the importance of this. Everybody believes in the outcome studies. So, but I think there are some barriers in terms of, for example, a major insurance company, I don't want to mention it on air, in the West Michigan, endocrinologists use a lot of insulin. So when we add GLPs, they want you to go through step therapy or fail metformin or fail this and that. These are all deterrences that we have a person who does prior authorization all day long. So it's nice for the collaborative to show us guidelines and stuff. But in the split of a second, when I'm sitting in the front of the patient, I want to give them a GLP of a certain choice. Then when I get a pushback a day or two later, I'll be discouraged to that because I don't want the headache. No matter how good intention we are for our patients, but coverage and for your study, and we never had a clear answer since the beginning of the collaborative approach. Who is going to fund the SGL2 and the GLPs in the Blue Cross study? Are we going to get samples? Are we going to get some kits for the study only, or just we go through the commercial coverage, which is beyond anybody's pay grade that all of us we do?
I mean, I think that's one of the goals of the collaborative. First of all, to identify what is the state of the affairs, to understand what are the main components that are leading to these percentages that we have seen, and then work with, obviously with Blue Cross Blue Shield in our initial steps to move forward the viable step to be implemented. And if we hear indeed, and we actually validate that across the entire MC2TD, it's not the lack of willingness, which I know that majority of us obviously don't want that, to try to implement these guidelines, but it's in fact the lack of insurance coverage. That's something that definitely will be addressed. But in order to have the strongest argument, right, when we go to negotiate something, we need to show them clear data. And that's how we are now making this progress in collecting and analyzing this data that highlights what's happening in the state of Michigan and how these guidelines can be implemented. Additionally, I think that it's very important that we are now also acquiring more and more data that demonstrates how, giving an SGLT2 inhibitor can save money down the line, because many of the insurance companies are thinking, on dollars. So that's why we are trying to do what we are doing here. But very pertinent points. Thank you very much. Jake, do you want to say anything more here?
I just wanted to, I wanted to ask a clarifying question that I could maybe address a little further. What Blue Cross Blue Shield study are you referring to? Were you thinking of MCT2D as a research project?
You are asking Dr. Katoub, right?
I was, yes. Thank you.
Yeah. I don't know whether he is still here.
Dr. Katoub, could you hear me? I can clarify anyway. In the chance that you were thinking of MCT2D as a research project, I did want to clarify. MCT2D is a quality improvement initiative. It is not a clinical research trial. So we are not enrolling patients per se into any kind of clinical trial. We are simply disseminating and trying to provide tools and resources to providers like yourself in order to use these guideline-directed therapies in patients with type 2 diabetes. We fully recognize that insurance coverage on these two medications is a huge barrier. It is something that we're approaching from a twofold approach. One, with policy advocacy with these insurance companies, as well as creating tools, tips, tricks any kind of documentation that we can provide to you as a resource in order to be able to get these medications covered for your patients. And so I just wanted to give that clarifying answer as well.
Well, thank you. I'm Al-Kassab, not Kutub. That's number one, if you're addressing me. And secondly, when the study started almost a year ago, when they were collecting the data, the idea was to spread the use of the SGL2 and the GLP because of the outcome study. And they wanted to start with the Blue Cross patients. The idea that was transmitted to us is don't care about coverage, don't care, because Blue Cross is going to embrace that and give it to their patients regardless of coverage. So we were wondering, how is that going to work with each individual plan? Now, I understand there is a collaboration, and I understand there is an educational component to this, but the data, the patients, we are the patients' kind of guardians. Therefore, the impression we got at the beginning is that we will be given the in fact, even the drug companies started coming to me and say, did you hear Blue Cross is going to give it away regardless of cost, regardless of this, because the idea was to improve the widespread coverage because of the outcome studies that was as a pilot project. So this was the impression. And thank you for the clarification. And I fully understand this is a collaborative project, but to give us resources and stuff is one thing, and to make sure that we prescribe and get the drug is another. We all know how to navigate this, but as a group, I think when you present them with the data, it will be much more helpful to make it, since we know that this drug is available on this plan, so that we don't get trying 2 or 3 times to find out the right combo.
Thank you very much. Anybody else has any other suggestions or would like to bring up thoughts regarding what we have presented? What other ideas we should implement?
Yeah, this is Dr. David Bradley from Bloomfield. What I do is I have the patients call their insurance company on which ones and get a list of which ones they cover for the SGLT2s and the GLP-1s. And then I pick the one that the insurance company, because they have to cover these now because of the MACEs. All the data shows the MACEs are there. There's no reason, and there's no real ethical reason that these insurance companies can hold this therapy anymore from anybody. So they have to have a formulary, and I have my patients call them instead of saying, is it this one? No. Is it that one? No. I have them call, they give me a list, and I pick off the list.
You are talking about people who had a prior cardiovascular event, right?
Well, and even in prevention now, because remember, we have the prevention data now too, that this helps prevent, this is going to, this not only they had prior, but they have damage, but this is protective, this is preventative. So it has to be on their formulary now, because the MACE data is there, and that's what they wanted all along, is things that prevented major cardiac, adverse events, and they're having this now.
So Dr. Bradley, you are telling us that in fact, with this approach, you have not encountered any more barriers in getting patients coverage for one.
Yes, as long as they call their insurance company, they have to have these drugs on the formulary. One of them's got to be covered because of the overwhelming MACE data, and I just pick the one that the insurance coverages, and I don't have any problems.
All right. Well, anybody else would like to comment on this?
I just want to say thank you for sharing that, Dr. Bradley. And I just wanted to show really quickly just a couple of things that we pulled together that kind of support Dr. Bradley's point. So we have 2 things. We have our coverage tracker for the medications that looks at like the different plans and their coverage and requirements for it. We update this quarterly. So this is like a good starting point to kind of see what plans are covering which medications for Medicare Advantage and for commercial payers, like we had mentioned. And also to Dr. Bradley's point about having the patients call and double check. We also have this insurance coverage worksheet that we've created too, where you as a provider can say, okay, we're recommending a GLP-1, and we have all these questions for the patients to call their insurance company and get that exact information. So they can understand like what's covered, but also things too, like their deductible, their copay on these medications, et cetera, so that they can understand that too. So hopefully these couple resources help you if you want to try to implement Dr. Bradley's method of getting these covered for your patients.
And those who are available and will be available to everybody to have.
Yep, they're on our MCT2D website.
But perhaps we can also make sure that we distribute them.
Yep.
Yeah.
Absolutely. We can email them out after the meeting.
All right.
This is Dr. Hamoud.
I also like the fact that when the patients call their insurance company, which they're paying their premiums, they're unlikely not to listen to them. They answer and they talk with them, versus when it's somebody else that may not be a vested interest, they can give you a little bit of a runaround.
But sometimes I have to say that I hear many of my patients complaining that they have to stay on hold for hours until they get to talk to someone. So that is true too. Anyway,
this is,
thank you so much, Dr. Bradley, for this.
This is
yes?
Dr. Hamoud.
Dr. Hamoud, go
Yes,
ahead.
I really think, as we know, all the endocrinologists are very busy and we are all short on staff. We really don't have time to fill forms. We don't have time to do prior authorization. That will take hours and hours. So the message have to be taken to the insurance. I mean, I'm just giving you an example. I know that we're discussing Blue Cross, but I do see Medicaid. Any Medicaid patient, somehow Lilly made a deal with the Medicaid, and I don't know how much they're, how they did it. They cover the Trulicity, and they don't have to fill any form. Just write the prescription. Patient come back in 2 months, very happy, lost weight. Anytime I see A1C in my office less than 7%, 90% of the time they are taking GLP-1. It's pretty simple. So why Medicaid insurance took that initiative, and the Blue Cross, which make tons of money, more than Medicaid, much richer, has $1 million, why they are not able to do it? I mean, it make a huge difference. I mean, in the long run, when you make patient lose weight and A1C in the 6%, you're gonna cut down on the dialysis and retinopathy and all the complication. I mean, eventually everybody is win-win situation. So the message really is we already have the study and we already have our clinical experience. We know that it works. It worked very efficiently. So and we don't have time to do prior authorization. I mean, we cannot hire a full-time. We're not hospitals. So the insurance have to take the initiative, make some deal with the drug company, get some discount, just make it available, just like the insulin initiative that the government trying to take. Make it another initiative for the SGLT2 inhibitor and GLP-1 to make it available for every insurance, where patients don't have to call, don't have to fill form, and definitely physicians don't have the time to do prior authorization.
Excellent point. Completely agree.
This is Mira Bijlani. I just wanted to kind of carry forward what Jacqueline was saying. So I actually did print out the stuff that we were talking to in terms of the coverage, but they also did a great job in follow through on that. They actually put together the list of the SGLT2s and GLP-1s, what company makes them, and what the contact numbers to call those companies are if they're looking for patient assistance. So a lot of times when they say it's expensive, one of the ways we do is we have them call the patient assistance line. And surprisingly, a whole bunch of patients qualify for some sort of assistance, which makes them a little bit more compliant with these agents.
Excellent.
So much for bringing that up, Dr. Bijlani. We'll send that out too with the resources that we disseminate post-meeting. And I'm so happy that it's helped some of your patients get these medications.
Yeah, it just cuts down on the discussion. We basically just end up saying, here's patient assistance information, try this. Sometimes they may not realize there were copay cards, there were patient assistance programs, but having that has been very helpful to us.
Yeah, I agree. Anybody else? We have a couple of more minutes. I would like to give everybody here in this group an opportunity to share your ideas and thoughts.
This is Dr. Verma. I'm driving, so I may be a little bit scratchy. But the cost to the patient, especially Medicare plans, it's a real issue. I mean, I would love to have every patient of mine on a GLP and SGLT2, but cost is still very much like it's the elephant in the room.
Right.
Nothing else
Just keep in mind that Yeah, the data
Yeah.
we shared with you was only a patient with Blue Cross Blue Shield PPO. So we didn't look at the Medicare yet. So,
Yeah.
but
Well, I kind of find it hard to believe that only 17% of my patients are on GLP-1. I would think that a lot.
this is an aggregate, it's an average, right? So
No, but I think it's true for all endocrinologists in this group.
mhm.
We would like to have everyone on them.
Agree.
And there are so many Blue Cross carve-out plans with high deductibles, and these patients don't qualify for patient assistance.
Mhm.
And so I think we have moved way beyond like what these drugs can do for the patients. We already know.
Exactly.
Yeah.
Yeah, we
just
know. Now the data is overwhelming, yes.
Yeah. So what we need to discuss if we want to make this a success is how to get more patients on it and not what the data is.
Yeah, I think that if we look even at our polls, there are some nuances that we can improve as well through, comfortability in prescribing these agents at lower EGFR levels, because even our own polls clearly show that there is still area where we can improve. But the cost, of course, are very important points.
Yeah.
Everybody else is making, yes.
With Mounjaro coming in, I mean, it's even going to get better.
Yes.
So I mean, we really have no doubts. I mean, if we use metformin for other reasons, and beyond that, these should be our go-to drugs after metformin. But a lot of times we are forced to use sulfonylureas low dose just because patients couldn't pay for it. Yes. And that's very true. It may not be for some PPO plans, but like if you look at Blue Cross Medicare Advantage plan, a lot of patients can't afford that percentage of copay that they have.
Mm-hmm. All right.
So that Blue Cross PPO would be a very small group that we would target, I would guess. But what about the rest of the Blue Crosses and others?
This is just preliminary data, as I said. It took us a long time to even get access to this, and we work as fast as we can. But we wanted to share with you at least this preliminary data today.
Yeah, to Dr. Vasili's point, we are working on getting additional data sources. We have a data use agreement that we're currently executing with Medicaid to get Medicaid claims data. We're working on getting Medicare claims data as well, Blue Care Network, working with the other insurers. So very preliminary, and we are working towards that all patient, all payer data set. It's complicated, but it is our goal to get there. Mm-hmm.
So then where do we go from here? We know that these drugs are great.
Exactly. So where do you think we should go from here? What are your thoughts?
Well, I mean, I have no clue.
Okay, fair enough. Anybody else?
I would, Dr. Hamoud, I would just ask Blue Cross to replicate what Medicaid did. They approved at least one GLP-1, and that's good enough. At least they should do what Medicaid is doing. I mean, it's poor. These Blue Cross patients pay $1,000 a month, and they're not getting, these drugs for type 2 diabetic. It's a must be available for these patients because it makes a huge difference. So we should really demand from Blue Cross to cover these medications. And if they aren't, I think they're too expensive, but they should, if they make deal with the drug company, they can come to bring prices down, like what the insulin company did with when they introduced also new insulin.
Yeah, and Blue Cross does cover Trulicity, Ozempic, and Victoza without a prior authorization. They don't cover Byetta, Bydureon, or Adlixin, but they do cover those three. And as far as like the copays and things like that, that does tend to be an ongoing conversation around what that looks like, because there's a lot of ability for different employer groups when setting their plan benefits to customize those and set them as whatever they want. So it's more on like the individual employer than the insurance company. But as far as from a coverage perspective, without prior authorization, that is what Blue Cross has in place.
You know, I know there's so many Blue Cross nowadays. We lose, you know, track of them. But I know that a lot of patients, we thought that this is a case. When we write a prescription, patient come back, this is not covered, period. And sometimes they ask for authorization, and that's another, you know, way of blocking patient access to the medication. So that happened, I would say, more than 50% of the time in a Blue Cross patient.
I'm wondering if what's happening in those cases is a little bit what Dr. Basui touched on around the limitations of this. So in different employer groups can elect to carve out their pharmacy benefit and not get their pharmacy benefit through the insurer that they're providing like their primary insurance through. So while someone may have Blue Cross coverage and it may look like Blue Cross coverage on their pharmacy card, it may actually say something like Magellan, and they've carved it out to a pharmacy benefit manager who may have completely different coverage on those medications that we have less insight into. One thing we've tried to do is on our dashboards that we've created for the program, we do know if a patient has a pharmacy carve out. So that would be somewhere that you could look like prior to prescribing, and I would suggest verifying, but to see if they do have that carve out. And unfortunately, we don't have great information on what that coverage looks like when there are carve outs, because those formularies or information like aren't as publicly available as the others. So in cases where practices have reached out to us and said like this person is Blue Cross, we thought it should be covered, why isn't it? And we take that individual patient to Blue Cross and discuss with them, they always say that it was a carve out patient, almost honestly 100% of the times. So just something to keep in mind. I think it would be due to carve outs. Mm-hmm.
Dr. Basui, you're muted.
I realized. Anyway, so it is 6 o'clock. We know how hard everybody's working and how busy you are. So we don't want to go beyond what we decided that we said that we will. Thank you so much for your extremely useful feedback. We really appreciate. Thanks for working with us, and we'll take all these suggestions, and we will continue also to get access to more and more data sets and continue to do our analysis. And hopefully we'll provide even a more clear picture when we meet next. Anything else, Jake and Jackie, that you want to add?
Nope, just thank you so much, Dr. Basui, for leading this discussion, and thank you all for your robust participation. We really appreciated hearing your input and your thoughts on this. As we mentioned, we're going to continue working on building out our more robust data set that we will look at in the future that includes things like heart failure status and ASCVD, and gives us more variables and things to look at when analyzing this data, as well as expanding like the payers that are included on this beyond just Blue Cross Blue Shield, as we mentioned. So when we have that additional data available, we would plan to kind of reconvene again and have some more discussions about where we are and where we think we can move forward as a collaborative. Mm-hmm. Okay.
Thank you
So much, everyone.
Have a great evening.
Thank you.
Bye.
Bye.
Bye, everyone.